I really appreciate being here, and I want to go over three aspects of spinal arthritis here, which I have been involved with for many years, but also which the SAA was either instrumental in either triggering or providing support for. And so, with no further ado, let's move on to talk about classification and epidemiology in spinal arthritis. This is a slightly old slide, but this sort of gives you the spectrum of disease that spinal arthritis represents, with ankylosing spondylitis being the prototype, but also entailing juvenile spinal arthritis, arthritis associated with inflammatory bowel disease, ulcerative colitis and Crohn's disease, which you see on TV all the time, reactive arthritis, which used to be called inaccurately Reiter syndrome, acute anterior uveitis, as well as psoriatic arthritis. It encompasses a whole spectrum of clinical details, ranging from, of course, sacroiliitis, as you can see an example of it on an X-ray there, to sausage toes, we call that dactylitis, nail pits, that's characteristic of psoriatic arthritis, and some of the X-ray changes you see in the fingers, the spine and spondylitis, psoriasis, uveitis, when you get at looking at there, and you can see that's an X-ray of a heel, and you can see the big heel spurs, both where the Achilles tendon inserts right here, as well as where the plantar fascia inserts right there. And of course, this is an MRI of the knee in a patient with spinal arthritis, showing the classic inflammation. That's the white stuff that we see with that. One of the most important ideas in spinal arthritis is the idea of starting from a denominator of chronic back pain. Chronic back pain is a really common thing in the United States. It's the second most common reason after colds for a visit to a primary care practitioner. And this is the National Health Nutrition Evaluation Survey, which looked at 5,103 nationally representative people down in 2009, 2010. Doctors Michael Wiseman and I actually designed the study in conjunction with the staff of the National Center for Health Statistics, and they carried it out all over the United States with that number of people. And we were quite surprised to find that 19.4%, or 1 out of every 5 people in the U.S. have chronic back pain, which is back pain present at least every day for at least 3 months of one's life. Well, it also is quite striking that 89% of that 19.4% were having back pain at the time that the questionnaire was actually administered to them. Now, one important feature of chronic back pain, or subset of chronic back pain, is this concept of inflammatory back pain. There are a variety of different ways it's been defined that you're looking at on the screen right now. But in general, this is back pain with onset before the age of 40 or 50. It's present, it's chronic, so it's present every day. It comes on slowly. It's associated with morning stiffness, and most importantly and discriminatingly, and this was actually coming out of a study that the SAA funded about 10 years ago called the SAA back pain study. We found the most specific question was back pain that improves with exercise and is not improved with rest. So this is a subset of that, a bigger concept of chronic back pain. And inflammatory back pain is what is classic for spinal arthritis. And so we looked at the prevalence of chronic back pain in the U.S. population, and in the NHANES study, and you can see it was 6.9%, or more than a third of those with chronic back pain had inflammatory back pain. And you can see that it's most common in those in the younger years of their life. So remember the massive economic burden superimposed by chronic back pain. And what was really surprising to us was to find that though ankylosing spondylitis is more common in men, that inflammatory back pain was actually more common in women as well as in Caucasian people, or whites, non-Hispanic whites. So that's a picture of a patient with classic ankylosing spondylitis. And you can readily appreciate there the bamboo spine that we see in a person with a fused spine. And it's the typical young man, which is and there are criteria for ankylosing spondylitis called the modified New York criteria, which were formulated by Seth Vanderlinden in 1984. Actually, they were first formulated in 1966, but he modified them to be more specific. And they entail having the clinical criteria of low back pain and stiffness for more than 3 months that improves with exercise and is not relieved with rest. In other words, inflammatory back pain, as well as limitation motion of the lumbar spine in both the side-to-side and frontal planes, and limitation of chest expansion relative to normal values correlated for age and sex, because in a large number of patients with ankylosing spondylitis, that the ribs actually fuse to the spine, and which markedly inhibits the ability to take a deep breath. And so it's one of these three clinical criteria plus satisfying the radiologic criteria, which is having an X-ray showing sacroiliitis or involvement of the sacroiliac joints. The problem with the New York criteria is that in the average patient, that they suffer with inflammatory back pain for up to 7 to 10 years before those X-rays actually turn positive and the patient fulfills the modified New York criteria. This is called non-radiographic axial spondyloarthritis. You can pick it up on MRI scanning, by the way. You pick it up right away on MRI scanning, and that's very important to note. And this has really shaken up our concept. Well, once ankylosing spondylitis to the more the greater concept of what we call spondyloarthritis, particularly axial spondyloarthritis. Now, some people never have spondyloarthritis and never get spinal involvement. They might get the dactylitis, the sausage fingers and toes, or the heel involvement, or the peripheral joint involvement that I talked about before, or the uveitis. And so we've sort of been reclassifying, and these labels that I showed at the first slide, psoriatic arthritis, reactive arthritis, arthritis associated with ulcerative colitis or Crohn's disease, undifferentiated spondyloarthritis, and juvenile spondyloarthritis, have been more or less folded into axial or peripheral spondyloarthritis. It's sort of a new way to which we're referring to these diseases. And the assessments in Spondylitis International Society, or ASAS, which is a group of spondylitis experts. I'm actually on their board of directors, but it's largely based in Europe, but it includes U.S. spondylologists also, and they have come up with criteria for axial spondyloarthritis, which include in a patient with chronic back pain lasting more than 3 months and with age onset less than 45 years, either having sacroiliitis on imaging, and that would be either by X-ray or MRI, or being HLA-B27 positive, and then having, in this case, one of these features you're looking at here, or if you're just B27 positive and don't have positive imaging, 2 of these features here. And this is given, these are actually criteria, I'm sorry for the yellow there, but they actually perform pretty well with reasonably good sensitivity and specificity. And they're not perfect, that's for sure. In fact, the FDA did have some concerns about these criteria, but nonetheless are the best thing we have right now. And if we look, in fact, and these are looking at 2 groups of patients with ankylosing spondylitis and non-radiographic axial spondyloarthritis from Germany. One is the German early spondyloarthritis inception cohort, and the other is a cohort from Herne. It's not a large number of patients, but they compared those who had the non-radiographic axial spondyloarthritis with those who had ankylosing spondylitis. And lo and behold, they did find some interesting differences, that there was a higher proportion of women in the group with non-radiographic axial spondyloarthritis, and that they tended to be, and not surprisingly because the spine isn't positive on standard X-rays yet, less functional impairment by this instrument that we use to assess that, as well as a lower frequency of an elevated C-reactive protein, which is a blood test your doctor should be using to assess disease activity in ankylosing spondylitis and axial spondyloarthritis. In fact, when we looked at the NHANES study, those 5,103 people I talked before, we were surprised to find the following things: that 29, actually it's 29, so there's a slide slightly off, of these 5,103 already were carrying a diagnosis of ankylosing spondylitis made by a rheumatologist, would be a prevalence actually of 0.57%. That we've looked at the overall frequency of axial spondyloarthritis, it was 1.4%. Okay, and again, more common in the younger age group, but surprisingly, given that ankylosing spondylitis is more common in men, about 2 to 1, that axial spondyloarthritis is more common in women. And in fact, when the German earlier spinal arthritis inception cohort looked at this, they found that about 40% overall of the people with non-radiographic axial spondyloarthritis never went on to develop ankylosing spondylitis, about 40%. Yet they were equally impaired as far as pain and ability to function, and that these people who never evolved were more likely to be women. So this has led to a paradigm, and this has helped. This is one of the reasons why the Spinal Association of America put together the back pain study, which you can see actually is on the SAA website. Is when should a patient with chronic back pain be referred to a rheumatologist? Well, first of all, if their disease onset is before the age of 45, if they have chronic back pain that is inflammatory back pain, have sacroiliitis on imaging, or HLA-B27, then they should be referred to a rheumatologist for further assessment. All right, so let's talk about genetics. Actually, the over 90% of the overall cause of ankylosing spondylitis is genetic. Okay, and that identical twins are much more likely to both get the disease than non-identical twins. To date, 42 genes have been identified from studies that actually have been largely done by us. And I have to say that this all began with the SAA family genetics project that was done by the SAA, started by the SAA in 1997. I actually was working with them on it. I was the research end of it, and led to the funding by the NIH of the North American Spondylitis Consortium, which in turn led to our program project grant, in which we have basically us and our collaborative network defined the genetics of this disease to a great extent. And so there is about 10% of the cause of AS that comes from the environment. The current theory comes that it's coming from largely probably the gut microbiome. In other words, the bacteria that live in your intestines. That each one of you are carrying about 5 pounds of bacteria either in you or on you. Believe it or not, most of these bacteria are good bacteria. They work with your body to help you interface with the environment. And in fact, your genetics system may help to determine which bacteria are favored to be living in your gut or even on your skin. But when these bacteria between the good bacteria and the bad bacteria get out of balance, we call it dysbiosis. Okay, microbial dysbiosis can happen either on the gut, when we get inflammatory bowel disease, and likely ankylosing spondylitis, or on the skin, which can lead to psoriasis and psoriatic arthritis. On top of that, and some of the genes give us this information, that there's also some genes that are involved in mechanical stress, such as on the enthyses like the Achilles tendon or the plantar fascial insertion or the like, that can also be involved in triggering the disease. 27 is the 600-pound gorilla here, and I'll show you how big it is. But it's present in 90% of patients with ankylosing spondylitis, and it's very high in other types of spinal arthritis. In the United States, it's present in 7.5% of white people. It's present in 4.6% of Hispanics and 1.1% of African Americans. And so it's definitely less common in African Americans, but it's still the 600-pound gorilla. And so the question is, what is your B27 actually doing to predispose you to get ankylosing spondylitis? Well, these HLA molecules are supposed to bind to a piece of protein called a peptide. And they, in turn, take that peptide and they present it to your immune cells, and it causes an immune response. So for years, we looked for a little piece of protein called a peptide that was actually specific for this disease. We've yet to find one. The other thing is that the B27 molecule is one of the more unstable of the HLA molecules, and it can unfold. It can fold the wrong way inside your cells, and give rise to what we call an unfolded protein response. There are some evidence for that. The other thing is that, and other HLA-B molecules can't do this, but HLA-B27 has this tendency to stick to itself and form homodimers. In other words, a homodimer means that you have two B27 molecules sticking together. That's where you get dimer from. And it's the same molecule, so there's homo. and that's because of a certain amino acid that is present in it. And these funny homodimers can get to the surface of the cell and get engaged with some of your immune cells called natural killer cells. The other issue is, now listen to this very carefully because I've been living this. Again, especially working the past 26 years at the county AIDS clinic, that people who are B27 positive handle certain infections more efficiently than a normal person who doesn't have B27. For example, if they get infected with HIV, if they get infected with hepatitis C, if they even get influenza, the flu, that these viruses, they're actually more efficient than a person who doesn't have B27 in dealing with them. Their immune response is just programmed just the right way that they have a much better outcome and prognosis if they get these viral infections. But there are other kinds of infections, specifically infections where the bacteria can take off its clothing, take off its cell walls, and get inside cells, that a person who is B27 positive has a big disadvantage against. Bacteria such as chlamydia or salmonella or shigella, and people who are B27 positive don't handle these well. And we know that in reactive arthritis, or what used to be called Reiter syndrome, the disease can actually be triggered by these bacteria. Then finally, HLA-B27 may actually influence the human microbiome. In other words, what bugs live inside your gut, and changes in those bugs in the gut, changes that may come from an infection or coming from the injudicious use of antibiotics and the like, may actually predispose to ankylosing spondylitis. Moving on. So there's another gene called B60 that can, we all have two HLA-Bs, okay? I have HLA-B55 and HLA-B8, for example. Well, B40, although it's a little tiny monkey instead of a big 600-pound gorilla, it can also additionally affect the risk for this disease. This has been seen in Chinese and whites and also in African Americans. Moving on, we now know there are up to 43 other genes that are involved in this disease. Now, with this circle here, oops, went the wrong direction. With this circle here represents HLA-B27, okay? And the rest of the circle are all those other genes that are listed right here. Okay, so what I'm trying to say here is that HLA-B27 is by far the big predisposer to this disease, and all these other genes are just providing a little bit of additional risk. And a lot of these genes work with each other. So genes that are important in one arm of the immune response called the IL-17 mediated immunity. This is going to be very important when we're talking about treatment. Genes that are involved in the function of certain of your white blood cells. Genes that are involved in the presentation of those little bits of protein to the immune system, or genes that are involved in sensing what bacteria are coming across the intestinal wall. All of these have been implicated in providing a small additional risk in getting this disease, and probably explain why not the majority of people who have B27 don't go on to develop spondylitis, because they don't have these other genes. Now, not only are genes important in susceptibility to disease, but they also help to determine the person who goes on to have a bad outcome. For example, this is a study that we published last year, where we looked at 1,500 patients with AS, and we found two genes that were associated with greater likelihood of the worse of the spine going on to fuse on X-ray. One's called rank ligand, where those of you with osteoporosis know that's a very important target for some of the osteoporosis drugs. And another's called cyclooxygenase 1. Now, some of you probably know what cyclooxygenase 1. That is the enzyme that your non-steroidal anti-inflammatory drugs like Aleve or Advil or indomethacin and the like, that actually they inhibit. So it's no surprise that we know that taking anti-inflammatory doses of non-steroidal anti-inflammatory drugs like Aleve or Advil or indomethacin or Mobic or the like, all of these actually slow down, if taken in higher doses, the progression of the ankylosing spondylitis. Okay, now we've gone out to thousands and thousands of patients because these little genes, these other genes other than B27 only have a little bit of impact. So you need to be looking at thousands of patients before you actually pick them up. And we've been able to find some new genes by getting our numbers way up. We're still increasing our numbers, but additional genes that encode those cytokine proteins that the new treatments, the biologic treatments, are targeting. Genes and showing new pathways in how we get the disease, genes that actually influence the gut microbiome, and genes that are actually now the target of the drug companies in developing new treatments. Okay, so this is actually very exciting and is a great proof of concept that we find a gene, we have a potential new treatment. So let's talk about treatment. These are the American College of Rheumatology Spondylitis Association of America Spinal Arthritis Treatment Guidelines that were just published in February. And what happened was, and I was also on the executive committee of this, we all got together. It was a very long, complicated process. And by the way, the Spondylitis Association of America provided some of the seed money to come up with these guidelines. But these are the recommendations that these experts in spinal arthritis, working through the American College of Rheumatology and the Spinal Arthritis Research and Treatment Network, came up with. And these have been developed by a very formal academic scientific process. So let's talk about that. So we get a patient with active ankylosing spondylitis. We recommend using full dose continuous non-steroidal anti-inflammatory drugs as a starting point. Okay, and I will tell you that both in our big ankylosing spondylitis cohort that I'll mention a little bit later, as well, many of you are actually probably part of that cohort, that only about 50% of people who have ankylosing spondylitis actually end up, 50% will be well controlled with non-steroidal anti-inflammatory drugs alone. Remember, I told you that these non-steroidals are actually disease modifying. They can, if taken in anti-inflammatory doses in a patient with active disease, slow down the radiographic progression. So what if you're in that 50% where the disease remains active despite taking full NSAIDs? And by the way, we'd have no preferred non-steroidal anti-inflammatory. One is good as the other as far as we're concerned. If you have stomach problems on the NSAID, then perhaps a COX-2 selective drug may be better. There's the so-called slow-acting drugs like sulfasalazine, and that's the one we particularly would talk about. There are some other ones like methotrexate, which really aren't very recommended at this stage of the game because there's not a lot of good data that they work. But they only work for peripheral joint disease. They don't work for enthesitis. They don't work for the axial disease. Okay, they do not work. So the fact of the matter is, if you're still having a lot of inflammatory back pain, despite full doses of non-steroidal anti-inflammatory drugs, you should be on a biologic. At the time these guidelines came out, that biologic would be a TNF blocker. I'm going to have things have already changed in this regard. We'll get to that. We don't prefer any one TNF blocker over the other unless you have recurrent iritis or inflammatory eye disease or inflammatory bowel disease, at which point we do not recommend etanercept. One of the monoclonals, such as infliximab, adalimumab, or two others that are out, golimumab and certolizumab, known as Symphony and Cimzia respectively, are recommended. These are all TNF monoclonals. We recommend those over etanercept if you've got a problem with recurrent iritis or inflammatory bowel disease. Otherwise, etanercept is just as good as all of the others. Now, for a few other things, we don't tend to recommend prednisone or systemic glucocorticoids. If a person has an inflammatory bowel disease flare or an iritis flare, they may have a place, but they're not really recommended for the spinal disease. Physical therapy is very, very important. Active over passive physical therapy. And we prefer the land-based physical therapy over aquatic, just because there's not a lot of evidence. The aquatic water therapy has not been well studied. That's the only reason why. For those who have isolated sacroiliitis, where the pain is mainly there, an injection that is CT or ultrasound guided may actually are recommended. For those with peripheral arthritis, we do joint injections. Those of you on this call who are my patients know we do a lot of joint injections. And in enthesitis, we also will inject areas where there's enthesitis, except we like to avoid the Achilles tendon or the patellar tendon because they're more prone to rupture with the steroids. We use AS-specific disease activity measures. We monitor SED rate and C-reactive protein, and we do recommend involvement with education is very important, as well as follow evaluation counseling for those who have spinal deformities. Move to the next slide now. For those who have stable AS, where they're not having a lot of active pain, we feel the recommendations are use your NSAIDs only on demand. If you're on a TNF blocker and you're well controlled, there's no evidence you need to also take a non-steroidal anti-inflammatory drug. Physical therapy is always recommended, as well as disease monitoring. Hip replacement is certainly recommended for those who have severe spinal involvement. There are these surgeons that do spinal straightening. These have there's a high risk of side effects and paralysis with these, so we recommend it should only be done at specialized centers. For those with iritis, we recommend treatment with the ophthalmologist, and if you have recurrent iritis, you should have steroid eye drops at home. And again, a monoclonal TNF blocker can be helpful here, but not etanercept. Likewise, with inflammatory bowel disease, we recommend TNF monoclonals over etanercept. So that's where we are right now, but things have changed. Now, this is looking at this is a look a year ago at our ankylosing spondylitis cohort that we currently follow. We actually have about 1,200 patients in, but these are looking at those that we had the information actually available on. And what we're looking at here is looking at years between 2004, 2005 through 2015, looking at the use of non-steroidal anti-inflammatory drugs, TNF blockers, and opiates, narcotics, and for pain. And what we have found is, even though because of the effectiveness of the TNF blockers, we see how the use of that has risen from approximately 40% to over 60% in this 12-year period. That actually, because of that, the use of non-steroidal anti-inflammatory drugs has actually gone down. But the use of opiates has remained stable. And so that is of concern, but it tells you that there's still an unmet need as far as dealing with chronic pain in patients with AS. And most importantly, determining whether the pain is actually coming from the AS or from another source, perhaps a spinal fracture or the like. Now, this is the confusing slide, I realize. This is looking at the interleukin, the IL-23, IL-17 axis in ankylosing spondylitis. Because I want to talk about some of the new things coming down the pike with you all. This is one of your white blood cells called dendritic cells. It produces interleukin-23, which acts on another white cell called a Th17 cell that causes production by that cell of all kinds of other cytokines, IL-7, different types of IL-17, IL-6, interleukin-6, interleukin-22, interleukin-26, interferon gamma, and TNF, okay? And these in turn will then act on other cells in your body, fibroblasts, macrophages, endothelial and epithelial cells like in the skin or the blood vessels, and will give rise to an inflammatory response. So we've been blocking TNF right now, which is further down the pathway. Now we're getting there a little bit earlier, and I'm going to talk about some of the drugs that are in the pipeline, because the first one that there are two that have met FDA approval. One, ustekinumab or Stelara, has been approved for psoriasis. It's currently in phase 3 trials in ankylosing spondylitis. It blocks interleukin-12 and 23. The first of the IL-17 blockers, secukinumab, which is known as Cosentyx, was approved by the FDA on January 14th, and this has been shown to be very effective in patients with AS. Why is this better or more exciting as opposed to TNF blockers? Because TNF blockers do have a high side effect profile. That there's a risk of certain infections, infections related to TB, for example. And although it's a very tiny risk, there's also the risk of lymphoma as well as the risk of skin cancers. Not melanoma, but some of the skin cancers you get from being out in the sun too much, like basal cell carcinoma. And these are risks with TNF blockers that simply are not seen with the IL-17 blockers. Okay, and secukinumab is now approved and is available. And by the way, I have not been involved in any trials of secukinumab. There is another one that is in phase 3 trials called ixekizumab by Eli Lilly. There was one that was, instead of attacking IL-17, was attacking the IL-17 receptor called brodalumab. That actually looked very good in its phase 3 trials for psoriatic arthritis, and then they had, for some reason, a number of suicides in the people in the trial, and the company chose to drop the drug and did not go forward for FDA approval. Coming a little further down the pike are the IL-23 blockers, and there's one from Janssen and there's one from Boehringer Ingelheim, and these are looking very promising in psoriasis as well as possibly for ankylosing spondylitis. And what was announced just this week in the news is that Boehringer Ingelheim and AbbVie are teaming up to make a hybrid molecule where part of the molecule is actually Humira, adalimumab, and the other part of the molecule is one of these IL-23 blockers, and that's going to be going into clinical trials very soon. What we're really excited about is that although our group it was the first to show that because the early data suggested to the contrary, that TNF blockers themselves do slow down radiographic progression. It is entirely possible these drugs will be more effective with a lower side effect profile. So this is a very exciting time as far as ankylosing spondylitis and its treatment is concerned. There's a lot of exciting stuff coming down the pike. And so I'll just conclude here by saying that ankylosing spondylitis is included in the broader category of axial spondyloarthritis. The prevalence of axial spondyloarthritis is between 1 and 1.5%, where the prevalence in the general population of ankylosing spondylitis is about 0.5 to 1%. B27 is the major gene. It involves for about 80% of the overall genetic risk. But overall, we only know about 30% of the overall risk because there are other genetic techniques that we have to look at, looking at how the genes interact with each other, look at rare variants of genes, that sometimes the gene can be promiscuous and copy itself, called copy number. All these need to be looked at further. The American College of Rheumatology, SPART, and the Spinal Association of America have established treatment guidelines for this disease. And although anti-TNF drugs have emerged as a mainstay of treatment, new drugs, particularly that block interleukin 17 or 23, are coming to market. In fact, one has already made it to market. I'll stop right here, and we'll work on the questions. No, it is not. Autoimmune diseases are diseases that are associated with different HLA genes, different family of HLA genes, are characterized by the production of antibodies to your own tissues, or to yourself, and are associated with a completely different network of genes. And in fact, although there are some common treatments, as a rule, a lot of the treatments that are used for them are not effective in spondyloarthritis. So with autoimmune disease, your body is attacking yourself. With spondyloarthritis and psoriasis and inflammatory bowel disease, something very different is happening. That here your body is the innocent bystander. Your body is fighting something, probably an innate infection or mechanical stress situation, those chemicals, those cytokines that are being produced by your immune cells are causing your body to be an innocent bystander, and this is basically collateral damage. So I guess that's the easiest way I can explain that. Very good question. I'll tell you why. Because if you'd have told me a couple of years ago that we could eradicate hepatitis C, I would have told you you're crazy. Now we can now. And in fact, newer treatments are coming out that are shutting off some of these diseases. And so I think that the answer is likely yes. That day may come. And it's a very exciting time to be a doctor. Of course, the treatment's getting more and more expensive, and that's another problem. But short answer, yes. Well, there are no data regarding either diet or using probiotics, looking at good bacteria to studies. But I will tell you, it has not been well studied. So the absence of data doesn't necessarily mean no. It's just that it has not been well studied. It probably would be a good place to study. Generally, your own genetic system determines what bacteria live in there. But as far as manipulating is concerned, we're not seeing anything. They up in the Northeast, they're doing fecal transplants, believe it or not. and that is an area that's being looked at right now. But I'm not aware of any data regarding ankylosing spondylitis at this point. Very good question, because I'm sure you all recall that some of these rarer side effects, but important side effects, only come out in the post-marketing studies, the phase 4 studies. You remember the whole problem with Vioxx, for example, which, as far as I'm concerned, should never have been discontinued, but that was part of the legal hysteria that was associated with it. But nonetheless, we only found it out much later. So generally, I would like to see some of these drugs out for a couple of years. Now, the fact of the matter is that these phase 3 studies that are required before the FDA will approve these drugs usually have gone several years already. So you know, the IL-17 secukinumab had at least 2 years of follow-up before it even went up for the FDA, and so they've got a couple of years under their belts already. But we have on the TNF blockers 15 years of experience, more than 15 years of experience, and we have a very good idea. We found that a lot of the hysteria over cancer was really overblown, for example. That was a big issue early on. But that, especially in AS, the risk for lymphoma is very, very, very low. I've only seen, in the thousands of patients I've taken care of, one case. And remember that lymphoma occurs about in 1% of the general population. And the one case I saw, it wasn't 100% sure that it came from the TNF blocker, but nonetheless, that is one that I saw. And by the way, that patient is on infliximab today. After his lymphoma was treated, because his disease came back, he's back on his Remicade. I mentioned one already. Again, there are just no data at this stage of the game that either diet or probiotics can help. And one recommendation is certainly that if you're going to places like Mexico, that you do take prophylactic antibiotics to try to prevent risk of one of these really nasty bugs that shed their cell walls and get inside cells. But beyond that, I mentioned the fecal transplants. That's in its very early stages of being mainly in the Northeast, but I'm not aware of too much else going on at current. As a rule, we do recommend holding the dose either during infection or during infections, and also immediately before and after surgery. If you're on a biologic, the current recommendation is that you not receive a live vaccine, and as I recall, the shingles vaccine is a live vaccine. I think there is an attenuated one that is either recently out or been developed, but you should not be getting live vaccines. I actually gave a radio program in KUHF on that several months ago. And when I was doing it, I reviewed everything that was out there. There are some places that are outside this country that are doing stem cells for arthritis. I'm not aware of any doing it for ankylosing spondylitis because you know, it's not an issue of resetting the immune system. It's an issue of dealing with some kind of hidden stimulus to which your body's reacting. So that would be the more important thing to try to eliminate. And the genetics have taught us that this mechanism may be important. So I am not optimistic. You know, I've reviewed the literature on arthritis in general in stem cell transplants, and it's rather discouraging. But you know, these people are doing it for profit, and a lot of people are going to them because they're desperate. But the fact of the matter is, there's not good data that in arthritis that it works. In other areas like in traumatic brain injury in children alike, we're seeing some very fantastic strides in this. Well, to the latter question, no, but things that are associated with flare-ups are interruption of medications, stress. Stress, no matter if you have an autoimmune disease or immune-mediated disease, which is what we call spinal arthritis, stress can certainly trigger a flare. Especially if you have reactive arthritis, getting a chlamydia or salmonella or Shigella infection could certainly be associated with a flare, and things you need to be very careful about. Well, we've talked about mechanical stress. It's not a well-studied area because I personally, in my AS patients, strongly believe in exercise. but I think overdoing it may be something to avoid. Well, uh, let's see. I'm on the board of directors of the Assessments and Spinal Analysis Society, and so we. In fact, I'm going to Vienna in 2 weeks to form treatment guidelines with EULAR, the European League Against Rheumatism, for the treatment of spinal arthritis. These will be updated from some of the ones I just presented. I just got back from China, where we have a very large cohorts in Shanghai and Shenzhen. We just completed a huge population study using the same instrument that we use in NHANES in a city in China, where we looked at 30,000 individuals. We're able to define the prevalence of AS in that group as well as predisposing factors, and we're currently being more granular in that study now, trying to learn more about it. We certainly on my program project grants, my co-PI Matthew Brown is in Australia. I'm heavily involved in spinal arthritis research efforts in Latin America. I was president of PANLAR, and I've been in virtually every Latin American country. We're currently reorganizing the spinal arthritis study groups. So I think the only place I'm leaving out now, we've done work in Siberia back in the 90s in this regard. The only place I'm leaving out is Antarctica, but we're working on. If we find a case there, I'll let you know. Well, there are a lot of studies that are suggesting that it has a good effect on pain. I know that there's actually a trial ongoing with a cannabinoid derivative in scleroderma in our own division right now. We're not looking at that in AS, but there's a fair amount of not well-controlled data suggesting it has a very good effect on pain. It does not, however, appear to be a disease modifier. I think the use of medical marijuana is increasingly all over the country. Though I am a child of the 60s, that's not an area I really delved into, so I can't say much more than that. Cosentyx is approved for the use of ankylosis and spondylitis for those who have failed non-steroidal anti-inflammatory drugs. I'm actually shifting quite a few of my people who have not had as good an effect at the TNFs over to Cosentyx right now. Your doctor could do it for any of you, but let me give you a little advice. There are two principles on which I practice medicine. One, if it ain't broke, don't fix it. And two, if you're not prepared to deal with the answer, don't ask the question. In the former case, if you're doing very well on your TNF blocker right now, it might be a good idea to stay on it, because sometimes people who go off it may not have had such a good response to Cosentyx and want to go back on their TNF blocker, may not respond so well the second time. HLA-B27 positivity is a good thing to have against a variety of viral infections. HIV has been the one that's been best studied. People who are HIV positive, and this goes back to the pre-treatment era in the 80s and early 90s, live twice as long as those who are B27 negative. We find that the body also has a supercharged immune response to hepatitis C, as well as the influenza. In fact, we think that the frequency in certain Native American tribes of HLA-B27 of over 50% of the tribe was that way back in time a flu epidemic wiped out all the B27 negatives. So those are three examples. Although it's not been well studied, it likely carries over to other viruses such as smallpox and the like. On the other hand, chlamydia, bugs that can live inside cells and escape immune surveillance, like chlamydia, salmonella, shigella, are problematic for people to be B27 positive. Matthew from Canada has raised the hypothesis the reason why we see so little HLA-B27 in populations that live around the equator is because malaria is able to live inside cells, and we think that's why there's very little HLA-B27 in the parts of the world around the equator, in Africa and South America. So it sort of works both ways. It's good for certain infections, bad for others. A very good question. The short answer is that it's been looked at, but not well. That this is kind of thing that needs more study. We know that people have given methotrexate to prevent antibody formation, and even though it's not recommended for treatment of AS itself, some doctors do use methotrexate and sulfasalazine to suppress antibody responses to anti-TNF agents, because that certainly can impact on the effectiveness of the anti-TNF agent. We currently recommend switching to another anti-TNF agent if antibodies become a real issue and things like what I mentioned, methotrexate, are not effective. But as a rule, we use very little methotrexate in this disease, and although it is possible to get antibody determinations in this disease, and we have a company in Holland that does it. Generally, it's not commonly done in clinical practice because it's hard to do. Now we're talking about my clinical experience, and the short answer is yes. I generally don't see as much active disease in people who've had long-standing disease, but there's a couple of reasons for that. A fused spine isn't going to hurt from inflammation anymore because it's fused. Okay. Now the entheses can still hurt, and the joints can still hurt, but once the spine is fused, it isn't hurting anymore unless, God forbid, you undergo trauma and have a spinal fracture, and that is why even trivial fracture can be a real problem for a person with a fused spine, because you've lost the cushioning effect of the disc, and these fused spines are all too frequently osteoporotic. Some people on biologics have had a very good response to that. The short answer is we don't do really well against fatigue. I do recommend an exercise program. That exercise programs at least a half hour a day, 5 days a week, of an exercise program, whether it could be walking or whatever, is important. We know that resistance training is important, especially in older individuals, and that these have been shown to actually diminish the sense of fatigue that patients feel. Conditioning is a big deal. Deconditioning by itself causes fatigue. Good question. For the latter, ask me in 6 months, because we're actually we have enough patient visits in our own ankylosis and spondylitis cohort that we share with Cedars-Sinai, the University of California, San Francisco, and the NIH Clinical Center to look at this question. So we are going to be analyzing that in the next few months, and I think we should, but for what we have out there, there have been no head-to-head studies with clinical trials, but that the response rates are very similar for all the TNF blockers, and that the official position of the American College of Rheumatology is that there is not a major difference in efficacy for the spinal pain or peripheral arthritis pain in any of the TNF blockers. We're going to drill down more on that in our own cohort in the next few months, and maybe I can answer that be a little smarter in that soon. Yes, the main contraindication is active inflammatory bowel disease. The one thing that secukinumab and the IL-17 blockers do not treat is inflammatory bowel disease, unlike the TNF blockers, which do a very good job against that, especially Crohn's disease. And so a person who has had recent active inflammatory bowel disease has a contraindication to the use of Cosentyx. As far as infections are concerned, we do not see the spectrum of infections with Cosentyx that we see with TNF blockers. We see there is an increased frequency of oral thrush, that Swiss cheese stuff in the back of your throat, but not of systemic fungal infections. So that is one side effect that is seen. It's a minor one, easy to manage, but the infections are less. Are they better than TNF blockers? Maybe. That's being looked at. There are trials that are phase 3 trials that are ongoing right now that are actually comparing some of the TNF agents and these drugs, and probably within a year we should have those data. Let me tell you something. Other than I have my patient with lymphoma who's back on Remicade. Okay, he demanded it. His doctors and MD Anderson said it was fine with them. Put him back on it. He's 2 years back onto it and is doing fine. I'm a little nervous nonetheless. But when we come to solid cancers like breast cancer or the like, there really is not any contraindication to the use of TNF blockers. Okay, there's no evidence of a link to non-lymphoma skin cancers other than basal cell carcinomas and non-melanoma skin cancers to the use of biologics and then increasing the risk for that. So I think we should get that off the table right away. And these registries with TNF blockers have, tens of thousands of patients in them, and they just don't see it. And this isn't a situation where the post-marketing studies are so important. Well, I know that Xeljanz, which is very useful in rheumatoid arthritis, did not perform as well in AS. But the Xeljanz targets. There are these proteins called JAK proteins, JAK, that are part of your immune system, and there's different forms of this. And Xeljanz targets JAK1, 1, and 3. Well, we have recently, just in the past few months, described a gene that is associated with AS called JAK2, and there are JAK2 inhibitors that are being produced by at least 2 different companies. I know that the JAK1/3 inhibitor is a pill, and these may be pills also, and so may be very promising. That's a little further down the pipeline, but there are other things that may be coming. Those are the main ones. The JAK2 inhibitors, and then the IL-17 and IL-23 blockers are really the main ones in the pipeline right now. The ASIS group has made the statement that if you don't have a significant effect within 12 weeks, then it's not working. When we did a modification that back in 2003 when they first came out here in the U.S., we was thinking more like 6 weeks. But I will tell you that the overwhelming majority of my patients who are on anti-TNF blockers respond within 24 to 48 hours. And that response will increase over the ensuing month or so, but that most have a pretty quick onset of response. Sure. Sure. Now it depends if it's an allergic reaction. There are other biologics that can be tried. If it's a question of antibody formation, if it's a question of lack of efficacy, the official recommendation of the American College of Rheumatology is that you try another TNF blocker. So the answer is yes. Unless you have some kind of an absolute contraindication, like severe tuberculosis, or something like that, and I guess one might say that having lymphoma would be an absolute contraindication. Again, I got caught in this one patient of mine was quite insistent, and if some of you know this, that once you've had your relief with your biologic, you have to go back to a time and place where you don't have that. When you have really bad AS, it can be really miserable, and that sort of prompted what I did with my patient. Well, certainly we do a lot of work with ankylosing spondylitis and spinal arthritis here at UT. We do both. We have our big ankylosing spondylitis cohort where I see the patient every 6 months. A number of people who have no access to a rheumatologist because of lack of insurance, the like, get a free visit with me every 6 months. We also do clinical trials. Here we've done a number of clinical trials over the years. We actually are going to be enrolling in an IL-17 trial in the next few months. So we do that here. There are clinical research organizations in town who do this commercially. I can tell you at a place like this, it's not really for profit because I don't get a cent for it. We're a state university. So both in our cohort studies as well as in our clinical trials, we welcome participants. For participation in them, my program manager, Laura Diekman, at 713-500-6852, is available in that regard. People actually call her all the time. She spends a lot of her day on the phone. Yeah, and and again, I know I've already mentioned this, the role of the SAA in the research that we've done going on, but I can assure you that the SAA has been a vital partner of ours over the years, and I've been on the medical advisory board actually since 1987, which dates me a bit, but nonetheless, it's been a very fulfilling partnership.
Say thank you to Dr. Reveille. for generously spending your time and your weekend with us and your expertise. I want to thank all the attendees. I'm deeply grateful to be part of such a vibrant and supportive community. And I want to express my gratitude to the Reagan Family Fund for funding this webinar series. As you can see on your screen now, there was a series of 4. I guess if there's one thing I want to leave with every attendee, is that it's to open and read the monthly email, the eSun. Breakthroughs in spondylitis research are announced there. It's concise and informative. There's our mission. We're looking for a cure and to help people live their lives to the fullest. Members receive Spondylitis Plus. It's a magazine, 20 to 28 pages long. It's color, research articles. We can include interviews and patient stories. We have a phone line that's available Monday through Friday. Our website, of course, has tons of information. We have hard copies, printed materials that we can distribute. We have a special site just for teenagers. We have message boards and social media. Message boards are like chat rooms, but with people who, there's a little more anonymity involved there. We also have support groups throughout the country. So, and if there's not one in your area, we can help you start one in your area. And Spondylitis Association has been doing this for 32 years, and it's been a pleasure.